This is Dr. Mimi Lamb from Metro Health Medical Center and Case Western Reserve University, and I would like to help you understand how disturbances in serum potassium affect muscle function, especially for cardiac muscle cells. Let's begin by looking at the equation that determines resting membrane potential for muscle cells. This equation says that resting membrane potential in millivolts is minus 61 times the log of a large term that contains both intracellular and extracellular concentrations of both potassium and sodium. Here, R equals 3/2, which is the ratio of sodium to potassium in sodium-potassium ATPase, which helps to regulate membrane potential in all cells by pulling out 3 sodiums for every 2 potassiums that enter the cell, thus helping to maintain an electronegative cell interior. So the normal value of the resting membrane potential for a cardiac myocyte is around minus 90 millivolts, with the cell interior being electronegative. Let's also do a quick overview of the phases of membrane depolarization and repolarization in the generation of a cardiac action potential. We begin with the resting membrane potential of minus 90 millivolts. The first phase is depolarization or upstroke, in which the membrane depolarizes and membrane potential becomes less negative, leading to the generation and propagation of an action potential. After depolarization comes early repolarization, followed by a plateau phase, and then by further repolarization back to the electronegative cell interior. Finally comes restoration of ionic concentrations, where all the ions go back to their normal resting places. So in the normal generation of an action potential, the initial depolarization causes sodium channels to open. Sodium moves into the cells, making the cell interior become less electronegative. This causes potassium channels to open, and since the cell interior is now less negative, potassium tends to move out. When the threshold potential of minus 70 millivolts is reached, sodium permeability increases even faster, and the rate of sodium entering the cell exceeds the rate of potassium going out, resulting in more depolarization, which leads to even more sodium channel activation, etc., and eventually to generation of an action potential, with changes being propagated to adjacent cells, resulting in transmission of electrical impulses and muscle contraction. Repolarization consists of first an early phase and then a short plateau during which calcium enters the cell through its slow channels, and then a final repolarization phase. During repolarization, there is minimal sodium permeability, so that the rate of potassium moving out is much greater than the rate of sodium moving in. Thus, the rate of repolarization, which is responsible for making the cell interior electronegative again, depends mainly on potassium permeability and efflux, which varies directly with plasma potassium concentration. During the recovery phase, pumps such as sodium-potassium ATPase and the sodium-calcium exchanger help put all the ions back in their normal places in time to get ready for the next depolarization. Now let's look at hypokalemia. Note that in the resting membrane potential equation, the magnitude of the membrane potential is determined largely by intracellular and extracellular potassium concentrations, which are each multiplied by R. In contrast, the coefficient for the sodium concentrations is only 0.01, so sodium contributes very little to the value of the log term. The ratio of intracellular to extracellular potassium also has an important effect on membrane potential. In hypokalemia, extracellular potassium concentration drops, and the ratio therefore increases. And when you multiply by minus 61, the resting membrane potential becomes even more negative. So you would expect the membrane hyperpolarization to make it harder to generate an action potential. But it turns out that membrane hyperpolarization also removes sodium channel inhibition, resulting in increased sodium entry into cells, producing increased neuromuscular and cardiac excitability, which is manifested as muscle weakness and/or cramps, and cardiac arrhythmias that are usually supraventricular, occurring as a result of increased automaticity of pacemaker cells. However, remember that repolarization occurs more slowly than normal because it is dependent on the rate of potassium efflux, which varies directly with plasma potassium concentration, opposite of what you would think. In other words, the lower the plasma potassium, the slower the efflux from the cells, and the longer the repolarization phase lasts. On the ECG, you can see delayed repolarization manifested by a widened T wave, which may also contain an extra little hump called the U wave. Thus, the manifestations of hypokalemia may include weakness, muscle cramps, delayed repolarization on ECG, and cardiac arrhythmias, usually supraventricular and related to faster depolarization and increased automaticity of pacemaker cells. In hyperkalemia, the opposite happens. Plasma potassium increases, the intracellular to extracellular ratio of potassium becomes smaller, the resting membrane potential becomes less negative, and you would expect easier depolarization. However, partial depolarization actually inactivates sodium channels, resulting in decreased membrane excitability, manifested as muscle weakness and even paralysis. Meanwhile, the high plasma potassium increases potassium permeability and efflux, allowing repolarization to occur more quickly. This is manifested as peaked or narrow T waves on the ECG, along with evidence of the delayed depolarization in the form of prolonged PR and QRS intervals. Thus, the manifestations of hyperkalemia include weakness and paralysis, faster repolarization on ECG with peaked T waves, and slower depolarization evidenced by longer PR and QRS intervals, increasing the likelihood of the QRS colliding with the T wave and triggering ventricular fibrillation. We'll end by considering a few clinical points. Interestingly, because resting membrane potential is so much influenced by the ratio of intracellular to extracellular potassium, hypokalemia caused by transcellular shift, such as acid-base disturbances, seems to produce more neuromuscular disturbances than hypokalemia caused purely by potassium loss. In general, as you can see, hyperkalemia is the disturbance to be more feared, since it tends to cause the deadly ventricular fibrillation, while hypokalemia tends to cause atrial arrhythmias. However, remember that there are other factors in producing these arrhythmias, such as accompanying electrolyte disturbances and other clinical conditions. For instance, hyperkalemia is often associated with renal failure and therefore with hypocalcemia and acidosis, both of which can increase susceptibility to ventricular fibrillation. But hypokalemia may be associated with diuretic use, which often means that the patient also has heart failure or hypertension, often with left ventricular dilation and/or hypertrophy, both of which carry risks of inducing ventricular arrhythmias that may be deadly as well. Note that abnormalities in serum potassium can present in a variety of ways. At the one end of the spectrum is a young woman I took care of who was admitted for Campylobacter diarrhea after handling raw chicken. She made a nice recovery, but on the day she was to be discharged, we noticed that her heart rhythm was irregular with frequent premature beats. We checked her serum potassium, and it was 2.8. We gave her some potassium, everything was fine, and she went on her way. At the other end of the spectrum are the dialysis patients who skip a treatment and/or overindulge in high potassium foods, who may go into cardiac arrest, or, if they are lucky, come to the emergency room with muscle weakness and are found to have a serum potassium of 9 or 11, and are emergently treated and stabilized with glucose, insulin, bicarbonate, calcium gluconate, and dialysis before they have a chance to progress to ventricular fibrillation. So, in summary, it is important to know the cardiac manifestations of hypo and hyperkalemia and to be able to recognize their effects on the ECG so that you can easily diagnose and treat them and someday perhaps save someone's life.